unnecessary post-exposure vaccine use will be reduced, and we can reduce vaccine wastage. Now, prevention of rabies. How can we prevent rabies? One thing is first aid. I told you, washing the wound thoroughly with soap and water for a few minutes and putting antiseptics like 70% alcohol, that is surgical spirit, and povidone iodine is very good antivirals. So this is mainly because it's an enveloped virus. Then the person should seek treatment from the nearest hospital. Now, from the hospital, if a person has not taken proper first aid, you have to give a small piece of soap. If the person goes to the market and get bitten there by a stray dog and straight come to hospital, sometimes not even wash the wound. So you should have some sort of a facility with a small tap somewhere and give a small piece of soap. Quickly go there and wash your wound for about 2-3 minutes with soap. Tetanus booster if indicated, antibiotics if necessary. And if the animal is suspected or possible to be having rabies, only you go for post-exposure. So before deciding, you have to screen the patient, screen the animal, and evaluate the situation when you are deciding whether you should go immediately for post-exposure or whether you can observe. Give me a second. Hello? Yeah. So the decision is made by going through all these factors. Screening the patient. Severity of the exposure. First, you have to see whether it's a major or a minor bite. So you know, I'm not going to go through all details how to differentiate a major, minor. This is in our protocol. All of you all should have a printout of the protocol, or you have it on your smartphone at hand where you can always refer to it. Whether the person has taken previous ARV. It is immaterial whether it was ARS and ARV or only a course of ARV, because the serum is given for a naive person to, tie the gap from the time that you give the vaccine for the person, for the time the production of antibodies takes place. So when a person comes as a second or a third exposure, where he or she has taken at least 2 or 3 doses of ARV, now WHO says even 2 doses are enough. But for us, still in Sri Lanka, we are happy to call a partial course if somebody has taken at least 3 doses of ARV in the past. How long, that is, it is immaterial. You can work with boosters because they have memory cells in them. In our T lymphocytes, there are some small T cells called memory cells. If you give an antigen, the person will have memory cells or memory response for that particular antigen. And with a subsequent, if the patient comes to you, you give 1 or 2 doses of ARV, the person will have an anamnestic, immediate shoot up of antibodies. So these are the 2 things you have to mainly ask or look into screening the person. Screening the animal. What animal is it? Is it an animal which is possible to transmit rabies? So if it is a crocodile bite, no, you don't have to worry. It is a cold-blooded animal. If it is a warm-blooded mammal, yes, it is possible. Whether the animal is observable or not. Okay? If the fellow is totally a stray animal or observable. Is the fellow at the time of the bite healthy or sick? If it is an observable animal, is it vaccinated or unvaccinated? If vaccinated, is the fellow well vaccinated for that animal's age or not? So these are the things you have to consider. When you analyze the situation, why did the fellow bite this person? Is it under a provoked situation or not? Now, sometimes doctors, when you call, they say, no, madam, it is not a provoked bite. But when you ask in detail, they say this outside, a person has gone into another person's compound. So for the dog, it is a provocation because dogs are territorial. They are the masters of that limit, their household. So when an outsider goes to another place, the fellow gets it's provoked. Whether it is a known biter. Now, some dogs they're habitual biters. Even the master, they bite for the slightest thing. And on the other hand, there are instances where the parents say, doctor, me balla kavadawat hapanne naha. අපේ දරුව මුගේ කරේ නැගගෙන කන්ද කැදලා මුගේ ඇඟ උඩ යනවා. But never bites. But today the fellow bit in an unusual way. That is a bit of a, suspicious thing that you have to take consider. Is it usual or unusual for the animal's behavior? So you have to spend some time. I know some hospitals, you are doing this in a busy OPD. That's why it is always recommended to have a separate unit for rabies. But in a small hospital for the whole day, if there are only 10-15 patients are coming, I know you can't have a separate unit. But at least in your OPD, 1 or 2 doctors who are interested in this, if you can direct the patients who come for the anti-rabies to these 2-3 doctors who are there, who will be looking after them, we can do a better job rather than everybody like without having like more experience in this. But I mean, if you are interested, you can just go through the protocol, go through it several times, you will master it. So this shows what is called a severe bite. I'm not going to go through in detail. If it is a severe or a major bite, if the person needs to be given treatment, you have to go for serum and vaccine. These kind of exposures are called minor exposures, categorized under minor. If it is a minor exposure, if the person needs to be treated, only a course of ARV is enough. Now, how do we manage scratch injuries? Now, this is there in our protocol. If it is a cat or a dog, and if the fellow is healthy and observable, irrespective of the vaccination status, because most of the time cats are not vaccinated in our country. But scratch injury, when you compare it with the bite, it's about 60 to 70 times less riskier. So it's, you don't have to go for immediate post-exposure. You can observe the animal for 14 days, even if it is unvaccinated animal. If the animal is, a key factor, animal should be healthy and observable. So you observe the fellow for 14 days and you wound manage and tell the person to keep a watch. This has very minimal risk, but there is a risk. But immediate post-exposure is not needed. But you have to very strongly spend some time and advise the patient. If there's any change in the animal, any illness, any behavior change, immediately run to hospital. Come back to start post-exposure. It can be animal go missing, die, meet with an accident, anything is possible. Immediately come for treatment. And if the person come after 2-3 days, because it's a minor exposure with a delayed presentation, you can start a modified schedule. But if the animal is suspicious or sick or die or unobservable, with a scratch injury comes immediately, consider it a minor exposure. It is a minor exposure, just go for the 2-site ARV. Immunoglobulin is usually not recommended, but very, very rarely with multiple deep scratches, unusual scratches, sometimes we may decide to go for serum and vaccine. I have seen 2 patients where we decided to go for serum because it was very unusual. It's the cat has been in attack mode, again and again has scratched the person.
Madam, if it scratches in the neck and face and neck, if
yes,
bleeding,
see doctor, if it is a very superficial kind of an accidental kind of a scratch, so you go back to the history and ask, why did the fellow scratch? Is it while playing, or sometimes one child throws the cat to another child and the fellow, when the fellow is falling, they try to hang on to something, so there's a scratch on the face. So in that kind of a situation, you don't have to worry. That is why I say always make your decision taking the whole picture into account. You can observe. But if the same deep scratch on the face, where the person was there and the animal has been in the attack mode, has jumped onto the person and has gone on scratching, now that is not normal. That is not usual. That kind of a situation, because it's in the face, going for serum and vaccine is acceptable. Okay?
Thank you, madam.
Right. There are 2 types of anti-rabies vaccines which are registered, that is Virocell vaccine and purified chick embryo cell vaccine, PCC. At the moment, we have both these products, and we have about 3 different brands in our hospitals. So doctor, it's important when you are treating, have an interest. Ask the nurses, what is the vaccine we have now? What is the brand? Because sometimes, and write on the card what is the brand you use. Why? Because sometimes some people may have an allergic reaction to a vaccine. Okay? And your hospital may be having Virocell vaccine from Serum Institute. Another hospital may have got, because from the MSV, they may be giving different vaccines to different hospitals. Another hospital may have a batch from maybe China, speed up. Another hospital may have got PCEC, that is chicken embryo cell vaccine. So if a person has an allergic reaction, because often we know allergic reaction is not due to the active ingredient in the vaccine most of the time. It is due to the excipients. Excipients are other things which are there in the vaccine to make the vaccine stable, or there may be antibiotics, trace amounts, because the virus is grown on cell cultures to prevent contamination. There's a bit of antifungals use, bit of antibiotics. So after even purifying the vaccine, there may be trace amounts. So each product from different manufacturers are slightly different. They are interchangeable. You start with one product, you can always continue with another product. But if a person develops an allergic reaction, if you know what is the product the person has been given, you can always try and go for another brand, because sometimes there will not, most of the time, the person will be quite okay with another product. That is one of the most important things why we say write the brand. Just write Virorabo, Cairo Rambo, Speeda, what is the brand? Then you know if there's a problem, we can give another brand to this person. Two routes of administration is there, intradermal and intramuscular. Most of our hospitals, government sector, we are using intradermal. More than 95% of our ARV consumption is through intradermal, because you know why? Because it's very cost effective. You use only 1/5 or even 1/10 of the dose. If it is a 1 ml vial, it is 1/10. If it is 1.5 ml vial, 1/5, but there's a bit of always a wastage. So at least from a 1 ml vial, you should be able to take at least 8 doses. When it comes to a 0.5 ml vial, at least we have to try and take 0.4. That is, at least 2 patients should be treated with 1 vial. And to do that, you have to have fixed needle syringes. I hope, doctors, you know what is a fixed needle syringe. That is the syringe, 1 cc syringe, which we try to maintain in the hospitals. I will give you I think one of the slides I do have the SR number. Please make a note of it, because if the pharmacist say, no doctor, you yourself can call MSD and ask whether this particular type of syringe is available, because we try to maintain it, because otherwise the vaccine wastage, because in the needle web, every time you inject 0.1, another 0.05 or 0.06 volume get trapped within the needle. Okay, so to prevent that, use always fixed needle syringes. Almost all the small hospitals also now we are giving intradermal, because even 1 patient, 2 patients coming to your hospital for a day, still it is cost effective. But still we have intramuscular schedule, which is needed. We will see to whom should we give intramuscular. So intradermal, this I have already mentioned, fixed needle syringes should be used. Whatever the brand, whatever the product, it is always intradermal dose is 0.1 ml. An IM dose is a full vial. So if it is a 1 ml vaccine, it is 1 ml. If it is a 0.5 ml vaccine, depending on the brand, it is the whole vial. Okay. PCEC always comes as a 1 ml. Virocell vaccine, there are both 0.5 most of the products, but Serum Institute Virocell vaccine is 1 ml. There are 2 types of schedules intradermal we use, the 2-site schedule and the 4-site schedule. Please don't unnecessarily use 4-site ARV thinking, it is bit more rapider in immune response, but don't waste even those extra 2 doses for all patients. So we keep the 4-site for some of the situations where the patient comes a bit late for a minor exposure, or when you go through the history, you are not 100% sure it is minor, like what we call a borderline. It's not definitely major, not minor, but in between. So you can go for the 4-site. The two-side schedule, all 4 days, you give 2 doses on day 0, 3, 7, and 30. The way this is written, there's a 0 here, that is for day 14, because in the intradermal schedule, normally there is no day 14, but there are certain instances where we give a day 14 also, like if we think that the patient has a bit of a risk. When it comes to the foresight, it is only 1 day, doctors, you give a foresight. Usually, if you start it at the beginning, on the first day, day not, you give a foresight and continue with the two side, because I have seen cards where people have given foresights on all 4 days. Please don't do that. You don't have to, right? It is only 1 day. Now, sometimes there are instances where a two-site is started, and on the day 3, the animal has died. And when you go back to the history, you wonder it's not really minor. It's a bit of a borderline or in a bit of a high-risk place, but a minor. We may go for a foresight on day 3. Okay. So likewise, you can like add a foresight on one point. Not necessarily it is always at day 0. So these are the places where you give foresight, a minor exposure coming 2-3 days later, or a borderline, or sometimes like in hospitals, a major bite where the animal is healthy and observable, and the fellow is either unvaccinated or improperly vaccinated. If the bite is due to a provoked situation, not in the head and neck. This is given in our protocol. We decide to go for a foresight ARV without going for serum, where ask the person to keep a more close monitoring. If by any chance, if the person comes back before the day 7 dose is given, saying that the animal is now sick or animal has gone missing or now dead, you can always go back to serum if you have not given the day 7 ARV dose. But if the person comes after giving the day 7 dose, doctors, you never go back to serum. Because if a person has taken not 7, now the person's immune response is beautifully geared and like a big machinery, it's starting to produce a lot of antibodies. At this point, if you go and give the serum, you mess up the whole situ. What you do is, if the day 7 dose has been given, you can give an extra maybe 2 site, as I told you, on day 14 if you are worried, but otherwise just continue. Intramuscular schedule, it is ARV entire vial given on day 0, 3, 7, 14 and 30. This is the 5-dose schedule, which always you should give this schedule if you have given serum. Because if you give serum, you don't go for the IM 211 schedule. There's a schedule which is recommended for minor exposures, which is called the Zagreb regime, where you give 2 doses of ARV, that is 2 entire vials, you give it to both deltoids and 1 each on day 7 and 21. Now, for example, a foreigner coming to your hospital with a stray dog bite who has not taken pre-exposure, because some of the foreigners, when you ask them, always see, because when they are visiting countries like ours, some people take pre-exposure, right? So if they have taken pre-exposure, you only have to give day 0 and day 3, whether it's a major bite or a minor bite or whatever. But if the person has not taken pre-exposure, if it is definitely a minor exposure, you can go for this 211 schedule, because it is easier for that person, because 4 doses given on 3 days, because they are in our country to look around the country, go around. So for them to come 5 days to hospital is not easy. But if it's a major bite, no 2 words. You have to give serum and the 5-dose schedule. And tell the person, look here, you can go to anywhere and get the next dose. Our all government big hospitals do have this vaccine. Take this card and go. Please write a nice card, because I got a nice comment one from a foreigner who came for the second time to our country, and he showed the card given from started from, I think it was Hambantota, started. Beautifully written. And he said last 2 doses he took it from his own country, and the doctors there passed this card around and said, my God, nicely written, because they have written serum given, first dose given, first and the second dose from Hambantota, and third dose from somewhere else, I forget. And the last dose, the fourth and the last dose, he had took it from his own country, and he visited our country again, and I met him and he showed this card and said like, I mean, I feel very proud to like hear things like that. So that is something, a minute extra you will be spending, right, with clear handwriting. Write the brand what you have given and tell the patient you can go to another hospital with this card and continue. So for a foreigner, it's easy if you for a minor exposure to go for 211 schedule. Okay. So who do we have to give the IM schedule? A person with an immunocompromised situation. Maybe a renal transplant patient or any other transplant patient, patient on long-term steroid, a cancer patient who is on chemotherapy, radiotherapy. Definitely, without going for intradermal, go for intramuscular because we are not sure whether that person will mount a good response with this small amount of antigen we are giving in the intradermal. Patients treated in the private sector, if you all are doing a private practice or if you all are working for a private hospital as locum doctors, in the private sector, we always give intramuscular schedule. Then international travelers, people who are even a local person who is going abroad, before the course is finished, always better to go for IM because it's easier for them to continue the schedule if given IM. Because some countries, they don't have the they don't use intradermal schedules because you have to have trained staff to do this. In the intradermal, when you reconstitute a vial of ARV, ideally you use it without much delay. But if you maintain it using like separate syringes and needles, which always you have to do, and sterile needle and syringe every time when you withdraw you keep the vial in 2 to 8 degrees in the refrigerator. You can use it for 6 hours maximum, maybe 8 hours is okay. So a small hospital, during your entire whole day session, you can use that one vial or 2 vials, okay? Now, immunoglobulin. What are the immunoglobulins we have? Equine, ERIG, human immunoglobulin, HRIG. Both these products, small amount of HRIG is also available. Doctors, we do have a small stock of human immunoglobulin in our MSD. Please tell your pharmacist to get down because MSD says without request they can't issue. So get down about maybe if you are a big hospital about 10 vials, if you are a small hospital about 5 vials of human immunoglobulin and keep it for necessary needy people. I will tell you to whom you should keep it. Majority of our hospitals now we are having like equine immunoglobulin and now you people are not even looking for human immunoglobulin because you don't do the ST for equine serum and the modern equine serum is very, very purified. There's a column purification, 2 steps. So that purifies the unnecessary protein. So the reaction rates are minimal. Giving serum is considered as an emergency. If the person needs to be given, if it's a stray dog bite or a suspicious animal, you should never keep a patient overnight. You have to do it in the night itself because we have lost people. We have lost children where they have come to the hospital, but our doctors have kept them overnight and given the serum the next day morning. So please don't do that. If the person has taken ARV without serum, if needed up to day 7 dose, if they have not taken, we can go back for serum. But if a person has not taken any treatment up to 3 months, WHO says you better go for serum and vaccine if it is a high risk. But in Sri Lanka, most of the time, I mean, if the person has waited for 3 months, nearly 3 months, we say go for a modified schedule, 422 schedule, because another WHO recommends serum even up to 3. But there's a maximum ceiling. Maximum for ERIG is 40 international units per kg body weight. For human, it is 20 international units per kg. But there is no minimum dose. So if it's a 70, 80 kilo man comes with a fingertip bite, you don't have to weigh the person, right? Look at the wound and decide how much serum do I need to infiltrate this wound well. යන්තම් උඩින් පල්ලෙන් නෙමෙයි, you have to use adequate amount of serum and infiltrate it well in and around as much as possible. So it depends on the place, anatomical position, how much serum can you infiltrate. If it's a fingertip, I mean a big finger also, maybe you can't infiltrate more than half or maximum 1 ml. It will be difficult to infiltrate even 1 ml. Okay, so infiltrate that, keep the serum without contaminating it in the refrigerator. You can always put it into this urine culture, those screw cap bottles are there, put it into one of them, keep it in the fridge and use it for the next patient. If it is a child with severe bites, now this child you have to weigh and see what is the maximum serum I should use. Okay, because otherwise you will be using a lot of serum and the child may not mount a good response for the vaccine when you follow through. Okay, that is why you should not exceed the upper limit. So what you should do is, if the child comes with a lot of bite, because their body weight is low, you weigh the child and see what is the maximum volume. And then consider, is this volume enough to infiltrate all the wounds? Sometimes that volume is also not enough. You may have to dilute it with normal saline. How much can you dilute? Twice or maximum up to 3 times. WHO does not recommend more than 3 times dilution, because sometimes doctors call and say, Madam, 3 times diluted also, this volume is not enough. What can we do? Maybe 1 or 2 ml more serum is okay, acceptable if it is a highly suspicious or a positive proven animal, because the risk is so high. You can take slightly more than the upper limit, but you should not exceed it too much. So in the weekly epidemiological report, it says rabies, and this is a part which is there, I have just included it for you to know. The category 3 kyanne our major bites. Okay. So what they say is RIG administration is recommended for category 3 exposures, individuals who have not previously been vaccinated against rabies. Even in the absence of RIG, thorough wound washing, accompanied by immediate vaccine administration and completion of the post-exposure prophylaxis, is highly effective in preventing rabies. In Sri Lanka, most of the time, now during our very bad economic crisis, we had few months where we had no vaccine, no serum in most of the but still we manage. But there are some countries in the African continent where they find it difficult to get serum. For them, they have said even go for ARV. Rabies vaccine should never be withheld, regardless of whether serum is there or not. For previously immunized individuals of all ages who have documented evidence of previous pre or post exposure, immunoglobulin is not indicated. No time limit. So equine serum, now the latest guideline says not to do a sensitivity test. Now you know you all are not doing sensitivity test anymore. You straight away administer the immunoglobulin or equine serum into and around the wounds. But however, it's a foreign protein. I mean, how much purified, some people may have a very rarely an allergic reaction, even anaphylaxis is a possibility. So always when you all are using equine serum, doctors, you have to be ready to tackle anaphylaxis. So always check and see in your immunization place whether adrenaline is available. Some hospitals, even sometimes, if a person gives a history of allergies for other things, they put a cannula and keep, because sometimes if there's a need, you can immediately start giving IV fluids. So this is, I think I have already gone through. Because WHO says giving the serum, this last one, no longer recommended injecting the remainder of the calculated drug intramuscularly at a distance to the wound, as evidence suggests that there is no or very little additional protection against rabies as compared with infiltration of the wound or wounds alone. That is why now we don't give the remaining part on the thigh. Now, what are the indications to use human immunoglobulins if and when, if you have it in your hospital? If a patient develops a severe reaction, we'll say a person with 3-4 bites, you infiltrate the first wound, you are infiltrating the second wound, suddenly you realize the patient starts sweating, blood pressure drops, and you stop and you resuscitate the patient. You give IV line, you maybe give a dose of adrenaline IM, and the patient recovers. Now, there are 2 other wounds which has to be infiltrated. You don't infiltrate it with equine serum. If you have human, you can infiltrate them. Another thing which can happen is if a person is having severe කියන්නේ මේ කසල කඩු දානවා කියන එක නෙමෙයි, right? It is anaphylaxis where the pressure drops, the person collapses, they say, for some drug or some food. If a person comes with that bad anaphylaxis history, if you have human immunoglobulin, you can go for that rather than going for equine serum. Another possibility is, like especially this could happen in a child where the parents show you 2-3 injuries, you infiltrate that, and then you start the ARV. The mother takes the child home. When the child was washed, mother notices another injury somewhere on the buttock region or somewhere, and the next day the mother brings the child again, says, "Ani doctor, mama දැක්කේ නෑ මේ තව තුවාලයක් තියෙනවා." Now, if you try to infiltrate that with equine serum, not that you can't do it, there's a higher chance that you may have a reaction, because now you may have sensitized the child after about 24 hours. Okay, so if you have human immunoglobulin, you can infiltrate a bit of human to this extra additional wound. So these are the indications to use human immunoglobulin, not a doctor's child or a relative or a nurse or somebody, right? So please don't waste the human immunoglobulin. It's very, very expensive compared to equine serum. A word about anti-rabies pre-exposure therapy. This is indicated for high-risk people, like people working with the virus in the labs, or veterinary surgeons, their support staff, wildlife officers, PHIs in the control program, animal quarantine workers, zoological gardens. Now, this kind of people are given pre-exposure. WHO recommend both intradermal and intramuscular. So, we are highly recommending intradermal for all healthy people, because you use only 0.1 ml one dose, right? Not even two sites, just 0.1 ml on one site. Because if it is IM, a whole vial on one side on day 0, 7 and 28. Now WHO recommend even 2 doses, that is day 0 and day 7 is considered as pre-exposure. You may come across, I have come across foreigners who come with day 0 and day 7 only, because now they are saying day 0 and 7 is considered as pre-exposure. So don't worry. Day 28 is not there. Worry when that is pre-exposure. You just can go for day 0 and day 3 boosters for them. Now, if these people are in this high risk, you are supposed to take a booster after 1 year and additional boosters once every 5 years if they can't do their antibody levels. RIG is not indicated if they come with an exposure to another animal bite. You only have to go for day 0, day 3. If it is intradermal, you can go for 2 sites on day 0, day 3. If it is IM, just 1 dose IM on day 0 and day 3. Now, these are some commonly asked questions. Ideally, if there's a large wound and a bad wound toilet should be done prior to infiltration. But if wound toilet needs anesthesia and you can't put the patient under anesthesia, the person is after a meal or something, you don't wait, do a good wound wash and infiltrate the wound with serum, and you do a later, like a secondary wound toilet or suturing later, maybe at least the next day. Keep at least about minimum 8 hours for the serum to act on the wound, because anti-rabies serum has antibodies against those glycoprotein spikes. If you remember that picture, there are like katu like, those are in the virus, those are the glycoprotein spikes. So the antibody is raised against the glycoprotein spike, where when you infiltrate the wounds, the antibody goes and covers the spikes, and that prevents the virus getting attached to the nerve endings to internalize into the nerve tissue. So give some time for that. Suturing a wound is done if the person needs to be given serum, should be infiltrated and then do the suturing, right? But if the person does not need anti-rabies post-exposure, you can go ahead, do a good wound wash, go ahead with suturing. Ideally, serum should be given before ARV, but it doesn't matter. If it is a small hospital, giving the ARV and sending the patient to a hospital where serum is there, it's okay. Pregnancy, lactation is not considered as contraindications. Okay? Pregnancy or lactation is not a contraindication. All patients who receive post-exposure should be given a properly written card. Clearly write the dates. Please, when you are writing the date, see to it that the date, month and the year is put. Sometimes you just put as 37. That is, after some time, even nobody remembers hatveni maase tungenidada tungeni maase hathvenidada. Okay, so always when you are putting a date, put the date, month, and the year. And also, as I told you, write what is the type of serum given, equine serum or what, and the type of vaccine used, the brand name, because for future if there's any reaction, and it's always good to know what is the brand the person has been given. Consider post-exposure therapy only for 6 squirrel bites. Now, this is also common, doctor. There are a lot of patients come to you all with a squirrel bite. So you take a bit of a history, because 6 squirrel we have come across positives. Still it's on, no? On it? Yes. Yeah. 6. Now, if we have never had any human getting rabies from a squirrel bite. What I mean is the small Tungiri lena, right? But a rock squirrel is a different animal. That's a big wild animal. There had been cases where rock squirrel bites, people have got rabies. So if it is a normal Tungiri small lena, if the fellow is like actively running and if apparently healthy looking, if they say bit them and ran off, you don't have to go for post-exposure. Don't worry. But if it is a sickly fellow, we don't take a chance, because one day it might happen for the first time. So in that case, going for a post-exposure is okay. Post-exposure is not recommended for house rat bites, because we have not had any rat positives in our country. So please don't waste vaccines. If a person was sleeping on a bed, especially the right hand, the other hand, which they are normally having the heat, if it's not properly washed with a bit of curry smell, it's very common to be bitten by rats in the night. So when you take the history, if it is highly possible, sometimes they may see the fellow, sometimes may not. If they see the fellow, definitely you don't have to worry. Don't go for unnecessary post-exposure. But if it is a very poor household, if the housing conditions are very poor and they are sleeping on the ground and there are like gullies opening, or sometimes the cement floor is broken and there are, like they say, that kind of a house, don't take a chance, because it can be even a bandicoot or even a mongoose. Any animal dying after a bite, encourage them to send the head for confirmation. Even human suspected rabies deaths, always the brain is supposed to be sent. There's a circular to send to MRI for confirmation. Human to human transmission of rabies has never occurred through natural ways. There are reports from corneal transplants, organ transplants, but human to human transmissions naturally has never occurred. So don't unnecessarily vaccinate. In one hospital, 23 people were given post-exposure just coming in contact or being close to a person who died of rabies, including the ambulance driver who took the person from one patient from one hospital to the other hospital. Okay, so please don't unnecessarily waste vaccine. Now this is the SR number, doctors. You take a note of those fixed needle syringes. Okay, this goes as the SR number to get to the MSD. Okay, just take a screenshot. In case of a suspected human death in a hospital, you have to order the post-mortem and send the fresh brain to MRI for confirmation. There is a circular. In 2016, there's a DGHS circular. You can download it. What to do if you have a suspected human rabies death in your hospital. Any adverse reaction following anti-rabies vaccine, you should report it. I mean, just not like a bit of redness or sometimes patients faint after the first dose of ARV, not that kind of thing. If it is a significant allergic reaction where you think it is definitely anaphylaxis, it should be reported to the direct MSD and Virologist MRI, Department of Rabies. And also you can always send a sample of blood to look for serum tryptase, because sometimes it's difficult to differentiate a faint attack, say syncope or vasovagal attack from anaphylaxis. Okay, so one way to see whether this is actually anaphylaxis is to look for serum tryptase about at least 6 hours, within about 6 to 8 hours after the reaction, you have to take the blood sample. And send another second sample, like to as the baseline, more than 24 hours later, another blood sample to see, compare it with. Immunology department MRI do this test. Where do we have rabies diagnostic laboratories in our country? There are not very many, only 3 places it is being done. MRI Rabies Reference Laboratory is the main lab where we are open 24 hours, 365 days, and we do it free of charge. Karapetiya Teaching Hospital, there is a virology laboratory, there is a rabies lab. They do, I don't think they accept brains in the night, but they also do it free of charge. Peradeniya Veterinary Faculty, there is a rabies lab. It is under the Ministry of Higher Education, and I think they are taking a charge for rabies diagnosis. So these are the 3 labs which rabies diagnosis is done. This is another common question which is, I think, you people come across. You give a card, the patient doesn't come on the correct day for vaccine. Now, how can we manage? If you remember, more than 95% of the cases, you don't have to restart a fresh schedule. You can work on it. Please take a screenshot of this, because I think this is very useful for you all. Because most of the time you can do a bit of like movement here and there and manage on the same schedule. The first question you ask is, patient miss a dose and come again later. First question you have to ask is whether we should continue this or not. Because if the animal is healthy and observable, and still healthy and observable, you don't have to worry. Now we'll say patient takes the day 0, goes and comes on day 7 without taking the day 3, saying that I had a maragadara or something, couldn't come. Now you first question you ask is, how is the dog? This is a semi-domestic animal, we'll say. Animal is still well and healthy. And then what you should do is, you mark it on the card saying the patient defaulted, came on day 7, animal is perfectly healthy. We decided not to continue. Advise the patient to observe the animal for 1 more week. And if there's any problem, because the chances are very unlikely, because our experience, we know at the time of the bite, a normal animal, within 2-3 days, they show some abnormal behavior. So by the 7th day, if the fellow is perfectly healthy, the chances are very, very unlikely. There will be a problem. Okay. Now, patient comes on day 7 after taking the day not, and when you ask, it's a stray dog. Now, this is a rare situation where you will have to restart, because now you can't continue on this, because not taken and patient coming on day 7. Here you will have to restart an ARV, again a new schedule, give a shelling, tell the patient, I vaccine nahati karanne, consider that day as day 0 and restart again day 3, day 7, day 30. Okay, that is one thing. Now, delay of day 3 dose up to about day 5, you don't worry, you just give it on that day. And if the gap is at least 2-3 days, day 3 and day 7 atare. So if it is too close to the day 7 dose, you ask the person to come maybe day 7 එක දවස් දෙකක් විතර delay කරාට කමක් නැහැ, to have a bit of a gap there. And day 30 you give it on the scheduled day. Okay. The delay of the day 7 dose is more flexible. Up to about day 13, if the patient comes, you just go and give that day 7 dose and give the day 30 on the scheduled day. But if the patient comes more than 2 weeks later, it can more than 2 weeks. What I mean is more than 1 week later from the day 7 dose. It can දවස් 14කුත් ගිහිල්ලා. If the animal is there, you just don't give it. But if the animal is not there or dead, you can go for a 4-site. Instead of a 2-site, go for a 4-site on that day and give the day 30 on the scheduled day. Okay. Now, a delay of the day 30 dose even more flexible. Right? If up to about 2 weeks delay, you just go and give that 2-site. If more than a 2-week delay, you finish it with a 4-site and finish it. Because sometimes, as I told you, අර ඩේට් එකේ මන්ත් එක දාන්න නැතුව අර ලිව්වම 3යි 7යි වගේ එහෙම නැත්නම් 5යි 4යි ඒ වගේ එකක් ලිව්වම ඩේට් එක මන්ත් එකත් එක්ක පැටලිලා may not come on the exact day, may be coming after a month or two. In that kind of a situation, not 37 taken, you just go for a foresight and finish it off, because the idea of giving this day 30 doses, doctors, to maintain long term immunity, because not 37 එක ගැහුවම patient කෙටි කාලීනව මාස කීපයකට හොඳ antibody level එකක් එනවා, which is enough for the protection. The last dose is given to maintain the antibody titers up to few years, because sometimes rabies there can be a very long incubations also. Okay, so that will be useful for you all. Thank you. Hopefully I have answered some of the queries you were having, and if you all have any queries, you can always ask me. Are there any questions?
Hello.
Yes.
Hello, yes.
Sorry for disturbing, madam. Just a question.
No problem. Please ask questions.
If a patient has been given post-exposure prophylaxis and comes back a few years later after a suspected bite,
Yes.
regardless of the duration, do we not give any post-exposure on this occasion, or?
No. Post-exposure, you have to give day 0 and day 3 only. You said it is a suspicious animal bite this time. Okay?
Yes.
Now the person has taken maybe serum or may not be with serum, at least 3 doses. For Sri Lanka, still we say partial, at least partial course. You never have to go for serum, even a major bite. No serum, no full course of ARV. In our protocol, doctors, because when we were revising, you just go through the protocol and see, we have mentioned if it is a partial course up to 10 years from that previous course, you go for day 0, day 3 without serum. But if it is more than 10 years later, go for a full course කියලා අපි දාලා තියෙනවා, because some of our physicians were worried. According to WHO, they say that is also for life. You don't have to go for even a full course, right? So that is what the memory cells do. You just go for day 0, day 3. අපි හිතමු ඔයාගේ patient එනවා දෙවනි සැරේට අල්ලපු ගෙදර බල්ලා හපලා තියෙන්නේ. නමුත් බල්ලා vaccinated නැහැ. But healthy and observable. You don't go for post-exposure. Don't go for boosters. What you do is you do a good wound management and tell the person, observe that animal for 2 weeks. Tell the owners, now we vaccinated නැති සතාව මේ සති දෙකේ vaccinate කරන්නත් එපා. ඌට ඉන්න විදියට ඉන්න දෙන්න. ඌ observe කරන්න, ඌ healthy ඉන්නවා නම් no worries. ඒ සති දෙකේ අතරදී මොනවා හරි වෙනසක් තියෙනවා නම් immediately to come back. හරි? අපි හිතමු 5th day එකේ ලෙඩා එනවා. ඩොක්ටර් මම අර කියපු විදිහට බලන් හිටියා, බල්ලා පොඩ්ඩක් දැන් අසනීපෙන් අද ටිකක් වමනේ දානවා. What do? You have to immediately go for 2 boosters, day 0, day 3.
Yes.
I would suggest to go for a foresight on day 0, because now you are giving this dose about 5 days after the person was bitten by the dog. It's a bit of a delay. To give a quick response, go for a foresight on day 0, go for a 2-site on day 3.
Okay, thank you.
Did I answer your question?
Yes, ma'am.
Hello.
Thank you.
Yes.
Madam, you know that as we know that all the vaccination are done for the domestic animals. So do you have any plan to vaccine for the stray dogs, stray animals?
Yeah, it is not the area, doctor. Now there's a place called Public Health Veterinary Services under the Ministry of Health. PHVS, Public Health Veterinary Services. There is now they are the people who are doing the animal control program. So it is they with the all MOHs and the area PHIs. There is a program going, but there are a lot of issues in the sense like now annually to do this program throughout the country, they are finding it so difficult because sometimes they have problems. They don't have enough vaccinators. Sometimes, some years, they find it difficult to get the animal anti-rabies vaccines to the area on time. Sometimes they don't have their vehicles to go from place to place. So likewise, it's difficult, and our people also try to depend only on the government. I mean, if you are rearing your dog, I mean, we are not asking them to give DHL, parvo, distemper. I mean, those diseases are okay. Even if they get it, the animal get it and animal dies. The only infection that we know of where a dog will transmit to human a deadly disease is rabies. So at least if the government program, if the animal, if they have not done annually to come and get it from the private sector, the people should be encouraged. That is also a part in our this responsible pet ownership, because with the situation our country is in, I mean, you all have to understand it's difficult for the public health veterinary services to conduct this program throughout the country every year. Now, there are some MOHs who are very active, very energetic, and somehow or other they fight and get the needed vaccines, and their PHIs are into it, and they are doing annual programs. So I told you there are some districts in the country which where the dog rabies control is better compared to some of the other places. So it's multifactorial, doctor. So there are so many factors which are there. But the problem is, even now the stray dog will say the fellow is vaccinated when the pulwang. But how now the patient comes and tells you, doctor, I was bitten by a stray dog. Now, how can you take a chance whether this animal is vaccinated or not? Even if it is vaccinated, you may have to go for post-exposure, because that animal is not observable for this person. Okay, so there is always a issue like that.
Madam, that thing is that, hello?
Yes.
Madam, can't we produce the vaccine to get the herd immunity for the whole the stray animal population?
In that case, it has to now herd immunity. There are two things. No, one thing is, in the population, if more than 70 to 80% of the dogs are vaccinated, that acts as a kind of a herd immunity. I hope you know exactly what is meant by herd immunity, right?
Yes.
In a area, a person or an animal who is susceptible may survive among the vaccinated protected group, because the infection අර R not කියලා එකක් තියෙන මෙහෙම එක සතෙක්ගෙන් තව තව සතුන්ට යන එක ඒකට වඩා the protective level is there. So one thing is for them to have more than 70 to 80% coverage. There is a possibility that there it is like even if something going rabbit, it will not be transmitted to close by other animals. So to maintain 70 to 80%, the megalo balduwama Lankai Gulga district coverage is around 50-55% maximum. There are few districts where they have gone up to about 68-70%. So that is a difficult task. Then another way of having a herd immunity is like oral polio dealer from feces, it contaminates the water, and expecting the ones who were not vaccinated to get some protection. Hema live bait system ekaput hari amarui, because live bait is done on vaccinia virus. It is sometimes people lameka hulangeka kෑවොත් එහෙම vaccinia also is not a very side effects තියෙනවා ඒ virus එකේ. So that's difficult. Now that kind of things are done in the Europe and in the Americas to control wildlife focus. ඒගොල්ලෝ helicopters වලින් ගිහිල්ලා live bait එක අතාරිනවා කැලෑවල් වල. Where the wild animals will, like, you know, ahunama එක කාලා to get immunized, because they cannot, jungle animals cannot be personally gone and injected. So that kind of thing. So these are, I mean, very difficult task. But in our country, this, you know, අපිට තියෙන පොඩි පොඩි strategies ටිකක් කරන්න. One thing is proper garbage removal. If there is no garbage, if there is no food around, there won't be animals. But our people, they are feeling very sorry for these animals and they go on feeding. So that is the this thing, this responsible pet ownership. Please accept that animal is now yours. Vaccinate the fellow. get the fellow sterilized, not to produce unnecessary puppies. ඒක නෙවෙයි puppies ලා දැම්මම උංග ගිහින් කොහේ යනකට පන්සලකට හරි ඉස්කෝලේකට හරි අතහැරලා එනවා රැට ගිහින්. You know, that is how now the stray population becomes more and more. So අපේ මිනිස්සුන් අපිට පුළුවන් නම් හදලා educate කරගන්න, this problem could be reduced, but there are so many practical issues.
Okay, madam.
Any other like ඔයගලන්ට guideline එකේ හරි අපේ treatment protocol එකේ if there's any issue or any unclear thing if you want to ask doctors? I hope all of you all have a copy of the soft copy එකක් තියෙනවද මේ අපේ හැමෝටම දැන් මේ smartphone තියෙනවනේ soft copy එකක් ඔයගොල්ලෝ ගාව තියෙනවද guideline එක? Because Dr. Mithunව contact කරන්න, he will send if you want.
Madam, මේක download
you have
කරගන්න
a group එකක් තියෙනවනේ. ඔන්න group එකට WhatsApp එකක් upload කරන්න. එතකොට all of you all please keep it. I mean nowadays you people are always on the phone මනේ. නේද? එතකොට අර කොලයක් තියාගෙන කොලේ ලාච්චුවේ හිටපු ගමන් නැති වෙනවා වගේ නෙමෙයි මේක අතේම තියෙනවා. If you need ටක්කල to open. But I can rest sure there will be a lot of patients who come to you which doesn't fall into this guideline also. I mean කොච්චර අපි guideline එකක් හැදුවත් there are I mean unheard of things something cropping up. So in that kind of a situation what we do is we use our experience and knowledge and try to answer. Okay, so I mean it always can happen. Any other questions?
Madam, the ARV schedule, when the patient
Yes.
comes for the day 30 vaccine, if the animal
Yes.
is healthy, do we have to give the day 30 vaccine?
නෑ ඩොක්ටර් day 14 එක අපි කියලාම තියෙනවනේ if the animal
Day
is
30,
එක බෑන්
day 30.
protocol එකේ තියෙනවා healthy observable animal කෙනෙක්ට you all have started ARV we very strongly we are telling you please stop because ලංකාවේ 60,000 vials විතර අවුරුද්දකට යනවලු anti rabies vaccines to give this unnecessary extra day 30 dose එක. If the animal is okay, please stop it. Because ඇත්තටම කියනවා නම් මෙයා ඔය 4 doses දුන්නද 3 doses විතරක් දීලා නතර කරාද කියන එක for a subsequent exposure it is not making any difference. අර අපි ලංකාවේ මම අර කිව්වේ අර අවුරුදු 10 අපි සීලින් එකක් දාගෙන තියෙනවා ඒ තව unnecessary dose එකක් දෙන්න කියලා. නැත්තම් not and 3 විතරයි දෙන්න කියන්නේ boosters.
And
Okay.
madam, the other thing is in the lecture, did you say that this suturing immediately on day 0 is okay for a wound?
Yes, if you do if a well vaccinated animal bites, right? You don't have to worry. You decide card එක බලනවා බලලා 4 සැරයක් vaccinated, last one within the past 1 year, you know this is a well animal and bitten under provoked situation. You are almost 99.9% sure there is not going to be any problem here. Now there's a big wound, gaping wound. You do a good wound management, you straight away you suture it. හරිද? But අපි හිතමු stray dog කෙනෙක් හපලා එනවා ලොකු තුවාලයක්. Now this needs anti-rabies serum. That and wound should be infiltrated first before you do the suturing. ඇයි මේ suture කරන්න එපා කියන්නේ? Because when you do the suturing, doctor, you are going through and through the tissues with your needle. You yourself may push the rabies virus inside a nerve. That is why it is said don't manipulate with that injury. You infiltrate the serum well. Give time for the antibody to go and get neutralize the glycoprotein spikes of the virus and prevent it from entering and give at least 8 hours. So best thing is to infiltrate today and do the suturing tomorrow. Okay?
Yes, ma'am. And the other thing is there's a interaction between betadine and ARS?
No. I don't know, doctor. This is something which is commonly asked from me. ඒක කොහෙන් ආපු දෙයක්ද දන්නේ නැහැ. බල්ලෝ කාපු තුවාල වලට betadine දාන්න එපා කියනවා. I mean, povidone iodine is a very good antiviral. Okay, cleaning the wound with povidone iodine is quite okay. There's nothing like that.
And the other thing is, to consider HRIG, do we give it to people who has allergies for anything like
Yes, I mentioned allergy කියන්නේ කසල පළු දානවා කියන allergy නෙමෙයි.
Right.
Please remember that. අපේ ලංකාවේ මිනිස්සු ගත්තොත් 80%ක්ම කියනවා මොනවා හරි දෙයකට කසනවා මාව කියලා. Okay?
Okay.
It is not මේ කැසුව පළු දානවා පොඩ්ඩක් නිකන් එහෙම නෙමෙයි බඩ රිදුනා loose motions දෙකක් තිබුණා ඒව නෙමෙයි. Anaphylaxis. A person says මාව bee sting එකකට මැරිලා වැටුණා වගේ වැටිලා ICU දාලා දවස් 3ක් ඉඳලා මම recover වුණේ. එහෙම නැත්නම් කියනවා මොකක් හරි food allergy එකකට or drug allergy එකට patient collapse වෙලා ICU දාලා recover වුණේ. That is anaphylaxis, doctor. If a person has had anaphylaxis for any drug or food or whatever, if you have human immunoglobulin, it is okay to go for that. But if you don't have human immunoglobulin, if the person even giving a history of anaphylaxis to something else, you can't help it in a ICU care, cannula එක දාගෙන adrenaline එක ළඟ තියාගෙන you infiltrate the wound. Because it is between life and death. But if it is අල්ලපු ගෙදර බල්ලා හොඳින් ඉන්නවා vaccinated නෑ, use your common sense. Please don't try to give serum to this patient. Always pros and cons බලලා decide කරන්න මම මේ කරන්න යන වැඩේ අත්‍යවශ්‍යද. Okay?
Yeah. Madam, and the other thing is there's a common norm saying that the people who are allergic to beef should not be given ERI.
No. Should not be නෙමෙයි. Should not be නෙමෙයි. A person who is allergic to beef may have a higher chance of having an allergic reaction to equine serum. Because horse protein and beef protein, there's some amount of cross immunity, cross reaction. There's nothing called you can't give. You have to be more cautious, doctor. And beef allergy කියලා අපේ මිනිස්සු කියන්නේ මේ anaphylaxis allergy නෙමෙයිනේ. beef කෑවම මට පොඩ්ඩක් බඩ රිදෙනවා. beef කෑවම මට පොඩ්ඩක් කසනවා පළු දානවා. ලංකාවේ මිනිස්සු ගොඩ දෙනෙක් beef කන්නේ නැහැ. එතකොට අපි දන්නේත් නැහැ මේකට beef allergy තියෙනවද කියලා. හරිද? So there's nothing called person with beef allergy you can't give equine serum. But you have to be more cautious. Okay?
Right. Thank you, madam.
Madam, how long does the immunity last after the boosters?
Nobody can say, doctor, that it lasts for this duration. It is very individual, variation is there. But normally with the course of vaccine, at least for few years, a person would have protection. But I mean, we have come across a situation about 22 years after a person taking anti-rabies post-exposure, we did the antibodies and very high titer was there. So it is very variable.
I mean that when normally we give boosters after partial course after 10 years or not. Then after 2 boosters, how long that immunity lasts?
That also nobody can exactly say. Sometimes maybe lifelong, maybe not. The thing is, I mean, we don't have the time and we don't have the facilities to do an antibody in a person who is bitten by a stray dog or something. So in that case, normally if you have taken a course of ARV and within 3 months, they say you don't have to go for any boosters. But if 3 months have passed, still maybe even unnecessarily we go for 2 booster doses.
Then after 3 months,
and day 3. And after giving that, a person who has taken a full course 10 years ago gets a stray dog bite and comes to you, you give day 0 and day 3. Yes. 1 year later, the person comes with again a stray dog bite. There are people who are again and again coming.
Yes.
Now that also, doctor, most probably now to answer your question, I'm pretty sure the person may be having protective levels. But the thing is, we can't take that risk without knowing that this person is having adequate antibody. එතකොට ආයිසරයක් not and 3-2 site එකක් හරි day not 4 site එකක් හරි දීලා patient එක යවන්න පුළුවන්. But කියන බල්ලා අපි හිතමු දැන් මේ patient එනම හපලා තියෙන්නේ මේ ගෙදර ගාවේ ඉන්න semi domestic සතෙක්. කාටවත් අයිතිකාරයෙකුත් නැහැ. නමුත් දැන් අවුරුදු 2-3ක් තිස්සේ තමන්ගේ ගෙවල් ළඟ hovering around බල්ලෙක්. ඒ සතා නම් I mean you can මට මේ අනකොට පොඩ්ඩක් මූ රෑ පෑගිලයි ડોක්ටර් හැපුවේ කියන්න පුළුවන්. But I mean you ask few questions. Patient has taken a full course of ARV and again 2 boosters 1 year ago. It's perfectly okay for you to ask the person to observe the animal for 2 weeks. Then අවුරුදු 2-3ක් හිටපු සතා I mean there's a quite a good chance තව සති දෙකක් ඉඳීනේ. Doctor, you have to use your common sense and see, what should I do this? Is it like, am I taking an undue risk with this person's life? Because අපි තුමු දවස් 5කට පස්සේ වුණත් මේ ලෙඩ ඇවිල්ලා කිව්වොත් අනේ ડોක්ටර් මේ සඩ්ලි අද මේ බස් එකට හැපිලා මැරුණා හරි. I mean, for you to go for day 0 and day 3 at that point is also not too late නේ. Because definitely this person is having quite a good
So can we check the
memorial
serological-
response.
Can we
මොකද?
check,
මොකද ડોක්ටර්?
can we check the serologically the immunity levels?
Antibodies may at MRI we you do this test, but at the moment we are having a small issue with our cell lines and we have stopped doing it. But the thing is, even if in a time that we are doing this is a test which is done as a tissue culture technique test. ටක් ගාලා කරන්න පුළුවන් ටෙස්ට් එකක් නෙමෙයි. අනිත් එක we charge 3,500 for a test. Government charge එකක් තියෙනවා. ඉතින් it takes time, so there's no possibility of a person immediately getting it done, doctor. So that is why I am telling you, if it is a stray animal bite or a highly suspicious animal bite or a positive proven bite, you can't take that chance. You will have to go for a day 0 and a day 3 boosters.
Okay, thank you.
Hari? Okay.
Madam,
Any other questions?
excuse me, Sarah, immunocompromised patient come with a minor bite, okay, minor exposure. That is, we have to go for serum.
මෙහෙමයි doctor.
Serum.
It is like, if it is like a not at all ලේ ආවෙම නෑ යන්තම් හැම කැඩිච්ච වගේ එකක් නම් 5 dose IM schedule. කවදාවත් 2-1 එකවත් යන්න එපා immunocompromised detector. හරිද? You go for the 5 dose IM schedule. But when you ask in detail, නිකන් අපි හිතමු බින්දු 2-3ක් වගේ 3-4ක් වගේ bleed වුණා නිකන් අර border line වගේ කියලා හිතෙනවා නම් in an immunocompromised patient, a stray dog or a highly suspicious or positive proven animal bite, it is always recommended to go for serum and vaccine. Okay? But definitely minor පොඩ්ඩක්වත් ලියාවේ නැහැ අන්තම් හැම කැඩුණා අන්තම් ලේ බින්දුවක් උඩට ඌස් වෙනා විතරයි මම ඒ වෙලෙම හොඳට සබන් ගාලා හේදුවා ඒ වගේ ලෙඩෙක්ට 5 dose IM schedule එක විතරක් ගියාට කමක් නැහැ.
Okay, madam. One other thing, how can you consider a puppy fully vaccinated?
How can we?
When do we consider
Puppy.
puppy a fully vaccinated puppy?
මෙහෙමයි. දැන් ideally සාමාන්‍යයෙන් පටන් ගන්න around 6 weeks නේ බලු පැටියෙක්ට vaccinate කරන්න. There are still some vet surgeons who says to wait for 3 months, which is wrong. Now from the veterinary people also, they are encouraging all vet surgeons to vaccinate a පැටියා at 6 weeks. WHO කියනවා 4 weeks වල දුන්නත් කමක් නැහැ. ඇයි ඕනකට වඩා වෙලසින් දෙන්න එපා කියන්නේ? හරියට අර දැන් අපේ බබාලගේ මේව හැම දෙන්නේ MMR හැම දෙන්නේ මාස 9න් ඊට ඉස්සෙල්ලා දෙන්න කැමති නැත්තේ there could be some amount of neutralization නේ. Okay, that is why ඉපදිච්ච ගමම දෙන්නේ නැහැ. අනිත් එක උන්ගේ immune system එකත් immature. So the ideal time what is considered is around 6 weeks. So you are supposed to give 1 dose at 6 weeks, and because their immune system is not very mature, you are supposed to give a booster about 1 to 3 months from the first dose to go for another dose as a booster. එතනින් පස්සේ තමයි annually vaccinate කරන්න කියන්නේ. That is the correct way of vaccinating. දැන් අපි හිතමු මාස 4ක 5ක බල්ලෙක් කෙනෙක්ව හපලා එනවා. That fellow has been given only 2 doses. 1 dose around 6 weeks and the second one is after 2 months from that first dose or after 1 month from that first dose. Then ඔය බල්ලට ඔయిత වඩා vaccinate කරන්න බෑනේ. I mean for that animal's age. So we have to consider that as okay, doctor. And if it is even a major bite, if the puppy is healthy and පොඩ්ඩක් විස්තර අහලා බලනකොට definitely a provoke situ කියලා හිතෙනවා නම් it is perfectly okay to vaccinate. Perfectly okay to observe, wound manage and observe.
Okay, madam. Thank you very much. Thank you, madam.
Madam, there is a wound
Yes.
with exposed underlying tissues, but there is no any bleeding. At that time, we take it as a major or minor.
කොතනද ඩොක්ටර් ආයි කියන්නේ උන්නේ?
After bite, big wound is there, but no bleeding. That
No
is
wound?
mean exposed
Big, මොකද මට තේරුන්නේ big wound එකක් නම් bleed වෙන්නේ නැතුව ඉන්න බෑනේ. මොකද ඔයා කියන්නේ කියලා තේරුන්නේ නැහැ.
අන්ඩර්ලයින් මැඩම් ටිෂූ ටික ඕපන් වෙලා රතු පාටට පේනවා. එහෙම වුණාට අර මේ බ්ලීඩ් වෙලා නැහැ.
ඒ කියන්නේ ෆැටි ටිෂූ ටිකක් වගේ එළියට ජට අවුට් එහෙමද?
ඔව්.
ඒ වගේ එකක්ද ඩොක්ටර්? ඇඟේ කොයි වගේ තැනකද? කොයි
මේ කියන්නේ මැඩම් අපිට ආවා බටොක් එකේ එහෙම තියෙන එකක් බ්ලීඩින් එකක් නැහැ. හැබැයි ලොකු wound එකක් තියෙනවා.
where was the wound?
බටොක්.
බටොක් එකේ. බටොක් එකේ ගොඩාක් ෆැටි ටිෂූ තියෙනවා. එච්චර මේ highly මේ වැස්කියුලර් නෑනේ. එතකොට බටොක් එකේ නිකන් අර ෆැටි ටිෂූ වගේ එළියට ඇවිල්ලා තිබ්බ. එහෙමද ඩොක්ටර්?
ඔව් මැඩම්.
මට ඒ වගේ හේක මෙයා එහෙම ලොකුවට බ්ලීඩින් නැති වුණා වුණත් මට හිතෙනවා ඒ කියන්නේ එළියට ටිෂූ මෙහෙම නිකන් එළියට වගේ ඇවිල්ලා වගේ තියෙන ටිකක් ලොකු තුවාලයක් නම් it's always safe if it's a stray dog or a unobservable animal. Going for serum is doctor, I think it's better. But එහෙම නිකන් අපි හිතමු නිකන් යන්තම් දතක් වැදිලා වගේ නිකන් තැනක් විතරයි නම් තියෙන්නේ එහෙම එළියට ලේ ආවේ නැහැ කිව්වොත් it is minor. You go only for ARP.
Okay, thank you madam.
What another like advice I tell you people is දැන් සමහර වෙලාවට තුවාලේ බලලා අපිට decide කරගන්න අමාරුයි මේක definitely minor ද definitely major ද කියලා. හරිද? ඒ අවස්ථාවේදී if the dog is a healthy observable dog කෙනෙක් නම් you push it towards minor side. ඒ කියන්නේ the risk එක හරිම minimal නේ. හරිද? ඒ වගේම if it is a stray dog or unobservable animal or sick animal, if you are in the middle like unsure නම් push it towards the major high risk side එක හින්දා. Because it's always good to go for serum and vaccine if that animal is suspicious or unobservable, rather than you are taking unnecessary risk by not being sure it is minor කියලා නිකන් ARV විතරක් දෙන එක. Okay, මට හිතෙන්නේ අර ළමන් කිව්වේ මේ අවුරුද්දේ අර මැරිච්ච 1.5 year old child. ඒක කොච්චර වුණත් ඒක අවුරුදු එකමාරක දරුවෙක්ගේ බෙල්ලේනේ තියෙන්නේ. So now we have to take the doctors this thing he or she I can't remember was telling that it was not a deep bite කියලා. But ඒ තනයි හොඳටම දන්නවා ඒ බල්ලා මිනිස්සු කීප දෙනෙක්ව හපලා බල්ලව මරලා දැම්මා කියන එක. I mean a wee bit of serum, just about 1 ml of serum උතන්ට infiltrate කරලා දැම්මා නම් we could have saved that child, no? I mean possibilities there, no? So අර ඒ වගේ අර risk එක හැමතිස්සෙම take the whole picture into account and decide, rather than going only at the wound or only at the animal's vaccination status or whatever. Okay?
Madam, head and neck area for healthy
මොකද?
head and neck area for healthy
Yes.
observable dog. Can we give foresight?
In our protocol, doctor, we have put like, head and neck involving major bite. Minor bite නම් ARV විතරක් ඇති. But if it's a major bite, head and neck area, healthy observable animal, you better not take a chance. In our protocol, we have put it as a situation where serum and vaccine will have to be given.
In head and neck area, madam, all bites are major.
Not all bites. No. Not all bites. Bleeding bites. If it is a superficial kind of a bite on the head and neck area, you don't have to go for serum. You can go for 2 site, or if it is like බින්දු දෙක තුනක් වගේ ආවයි කියනවා නම් modified හැටියට අරගෙන borderline වගේ අරන් 4-2 වලට යන්න පුළුවන්.
Excuse me, madam, in that situation where it's a major bite in the neck, if the dog is fully vaccinated and observable, do we still give serum?
No. ඇඟේ කොහේ වුණත් කමක් නැහැ බයිට් එක කොච්චර මේ මේජර් බයිට් එකක් වුණත් if the animal is healthy observable and well vaccinated, you don't go for post. ඉතින් එහෙමනම් අනේ ડોක්ටර් අපි බල්ලව vaccinate කරන්නේ මොනවටද? බල්ලෙක්ව හොඳට vaccinate කරලා තියෙනවා you don't go for post exposure. You just tell the කොච්චරවත් ලංකාව වගේ රටක අර සති දෙක observation period එක මෙන්න මේ කාලය you have to keep observing මොනවා කියනවා නම් එන්න කියන advice එක දෙන්න ඕනේ. But you don't go for any post exposure. You go ahead and suture the wound, you give an antibiotic. ඒ ටික ඒ විදිහට කරලා සතාව observe කරන්න කියනවා. Okay?
Okay.
Madam, major exposure, contamination of mucous membrane. If it is a major exposure, how do you give serum?
Infiltrate. That's a good question, doctor. හරිද? දැන් lick on lick on the mouth වගේ දෙයක්. එහෙම නැත්නම් splash of what do you call saliva into the mouth. Ideally considered as a major exposure. උතන පොඩි grey area එකක් තියෙනවා. even WHO guideline එකේවත් හරියට කියලා නැහැ. ඒක මේජර් සීරම් ඇන්ඩ් වැක්සින් දෙන්න කියලා තියෙන උනාට කොහොමද මේක කරන්නේ? So what we normally recommend is ඒ අවස්ථාවේදී අපි සීරම් අර maximum volume එකට ගන්නවා patient වේ කරලා අරගෙන ඉවර වෙලා just divided and give it on the thigh කියලා කියන එක විතරයි. That is, but when it comes to me මම අහන කියන දෙයක් තමයි හොඳට අහලා බලන්න are they quite 100% වගේ sure definitely මේ කෙල සතාගේ කටට මේ ගියා කියන එක. මොකද සමහරලාට අම්මලා කියනවා බබා සෙල්ලම් කර කර හිටියා ડોක්ටර් මූණ ලෙව කන්න ඇති, කට ලෙව කන්න ඇති. අර ඒ වගේ kind of a history and the next day the dog dies and this is a positive. Okay? Now that kind of a thing එහෙම නිකන් අර doubt එකක් විතරයි නම් මම නම් කියන්නේ modified එක ඇති කියලා. 422 එකක් ඇති කියලා. දැන් අපිට එනවා human දැන් මම කියවනේ unnecessary human exposures දෙන්න එපා කියලා අනිත් අයට. then it is not a very rare thing. A husband dies of rabies and now the wife comes and tells you, "Ane doctor, there was sexual contact within the last few days." Right? මොකද අපි කරන්නේ? අපි humane පැත්තෙන් බලලා we are going for serum for her නේ. එතකොට අපි කරන්නේ ඉතින් මේක කවුරුත් දන්නේ නැහැ මේ කරන දේ හරිද කියලා WHO එක කියන්නේත් නෑ අපිට හරියට මොකක්ද කියලා. Just like ඕක මම ওই question එක I have asked from even people who are from the other countries also, what do they do? So what most of the people they practice is they go for the higher the amount according to the body weight, maximum dose එක අරගෙන in divided doses you give it on the two thighs. Anterolateral side එකට නිකන් අපි සාමාන්‍යයෙන් දෙන විදිහට ඒ thigh muscle එකට දෙන්න කියලා. I think whether this is actually needed or not. I mean other වෙනතුරු ලෝකේ කවදාවත් එහෙම human rabies එකක් ඇවිල්ලා නැහැනේ natural ways වලින්. හැබැයි නෑ මොකුත් වෙන්නේ නැහැ ඕනේ නැහැ කියලා නිකන් ඉන්නත් බයයි. So there are a few gray areas like that where sometimes none of us are very sure whether what we are doing is exactly right. But the thing is, doctor, this is 100% fatal illness. I think සමහර වෙලාවට තියෙනවා නිකන් when you are not very sure, maybe we are going for unnecessary treatment. Okay, I think we
Madam,
shall we stop then?
Madam,
Was there another question? Yes.
Yes, madam. That we had one baby, 6-year-old one. The history
Yes.
of that scratch over the finger. That puppy. That is a puppy, madam. A 2 months old puppy. That only scratch mark. Then what to do, madam? That we have to observe for.
මට ඉතින් ඌ දෙවන මගේ කෙස් ගලව ගන්න හිතෙනවා මට දැන් මම මෙච්චර වෙලා ප්‍රසන්ට් කරපු එකේ වැඩක් නැහැනේ. දැන් ඒකේ කිව්වනේ healthy observable cat scratches, dog scratches, no immediate post exposure. In one of my slides it was shown. You just observe because scratches, cat or dog scratches have minimal risk. You just observe. දැන් ඔයා ඔය කියන කේස් එකේ puppy healthy observable කියලා කිව්වනේ මුකුත් කරන්නේ සති දෙක observation. නමුත් අපි හිතමු stray cat කෙනෙක්ගෙන් ඔය incident එක වෙලා ආව නම් consider it as a minor exposure, you go for a two side.
Then, madam, within that observable 2 weeks, if that puppy died or something, then
Oh, ඉතින් එතකොට you immediately ඒකට advice එක දෙන්න කියලා මම ලියලා තිබ්බනේ.
Yes.
advice එක දෙන්න ඕනේ සතාව බලන්න මොනවා හරි ප්‍රශ්නයක් තියෙනවා මේ කාලේදී immediately come back. So depending on the time that the person comes back අපි හිතමු අද කියලා හෙටම ආවොත් going for a 2 site is enough. අද මේක කියලා ගිහලා දවස් 4-5කින් ලෙඩ ඇවිල්ලා කියනවා පපි ටිකක් සනීප නෑ හරි සනියාගියතක් නෑ හරි you start a modified schedule 4-2 එකක් පටන් ගන්න. මොකද ඒක definitely it's a minor exposure but with a delayed now presentation වගේනේ. අපි පටන් ගන්න delay වෙලානේ. එතකොට foresight වලින් පටන් ගන්න ARV එක continue කරනවා. Okay?
Thank you, madam. Yes.
Okay.
Madam?
We got a question to our chat books.
Hari.
I think it's some sort of important question.
Yes.
If there is a needle prick injury with contamination from rabies patient, should we consider?
No, anti-rabies, no. There's a chat box, there had been a question asking a rabies patient, like a needle stick injury to maybe a healthcare personnel, whether we should go for post-exposure. Definitely not. Because one thing is, rabies, there's no viremia. There's no virus in the blood. Okay? And needle stick injury එකකට අපි ඒක බලන්නේ නැහැ. But එතනදි බලන්න ඕනේ දෙයක් තමයි things like hepatitis B, hepatitis C, HIV. So you have to quickly get a sample of blood from the person and send it for screening for HIV, hepatitis B, hepatitis C if there was a needle stick injury. But you don't worry about anti-rabies.
Madam,
එතනදී මට මතක් වුණේ common දෙයක් තමයි ඔය patients ලා ඇවිල්ලා කියනවා මෙහෙම බල්ලව අරගෙන යනකොට vaccinate කරන්න බල්ලට injection එක ගහලා ඉවර වෙලා doctor අතෙන් ඒ needle එක ඇනුණා කියලා මේ ඒ person ගේ අතේ බල්ලා මෙහෙම අත් දෙකට මෙහෙම අල්ලගෙන යනකොට ඒ වගේව වෙලා තියෙනවා. එතනදිත් අපි කියන advice එක තමයි එබෙල නිකන් හොඳට tap එකට අල්ලලා ඒ තුවාලේ හේදුවා මිසක් as far as we know there are no viral infections transmitted between like hepatitis viruses එහෙම වුණත් between dogs and humans. So you just wash it away, don't worry කියලා reassure කරන්න විතරයි තියෙන්නේ.
For the initial part, we couldn't join for the initial part due to the maximum number of participants have joined. Can we get the recording?
Yes. Dr. Mithun is, I think, has got a recording. He will make it for you all and he'll send it.
Hello, madam. There's another one question.
Yeah.
Madam,
Dr. Mithun will inform how you all can access it, how he will do it.
Excuse me, madam. Another one question.
It has been recorded. Okay?
Madam,
Thank you.
පූසෙක් දැන් අපි කියමු madam මාළු කට්ටක් කාලා කකා ඉද්දි කෑපු ගමම වගේ අපේ අතේ යනවා මේ පූසා කාපු මාළු කට්ට. ඒක එක්ස්පෝෂර් එකක් විතර ගන්නවා.
No, we don't consider it. Ekat hari common doctor, then go stray dogs la. Good that you asked that question. Then samalata amma kenek kiyenawa ballek mema daruwa mema banis kælla kala atha pahalata karan innakota stray dog kenek ඇවිල්ලා banis එකෙන් කැල්ලක් කඩලා ගත්තා. බබා ඉක්මනට ඉතුරු ටික කටේ දාගෙන කෑවා. ඔනේ අර බල්ලාගේ කෙල ගැවෙන්න පුළුවන් නේ banis එකේ. ඒ වගේ දෙයක් තමයි ඔය අහුවේ. ඒ වගේ දේවල් වලට we just reassure doctor. There had never been in the world people getting rabies from that kind of indirect like far-fetched kind of things. බල්ලෙක් බෝල් එකෙන් වතුර මේ මොකද්ද වතුර බීලා තියෙනවා ඒ බෝල් එකේ තිබිච්ච වතුර ටිකෙන් කකුල හේදුවා කකුලේ තුවාලයක් තිබ්බ ඕ වගේ මිනිස්සු එක දේවල් කියනවා. හරි? So don't worry, we don't consider them as exposures.
Thank you, madam.
Hello, madam.
Yes.
Madam, you had mentioned about the IM schedule of the ARV after a major bite, madam. Is that mandatory that after a major bite, when we give serum, that the ARV schedule is always IM?
Yes. Always 5-dose schedule you are supposed to give. The reason being, doctor, when you are giving ARV after serum, there has to be a day 3 dose also. Because in the 2-1-1 schedule, you give 2 doses on day 0 and give the next dose on day 7. Because when you flood the patient with serum, අර initial dose එකට එච්චර හොඳ immune response එකක් අපේ ඇඟේ එන්නේ නැහැ. Because it is our body is like a factory. If there are plenty of things available, you don't have to manufacture unnecessarily. the patient අපි සීරම් දීලා ෆ්ලඩ් කරපු වෙලාවේ දීපු ARV එකට අපි ටිකක් හරි කම්මැලියෙන් තමයි අපේ ඇන්ටිබොඩි රිස්පොන්ස් එක ඇඟේ එන්නේ. ඊළඟට day 3 එක යනකොට තමයි machinery එකට හොඳට ගිය වෙලා පටන් ගන්නෙ. So that is why it is always mandatory if you give serum you have to give a course of ARV with a day 3 dose also. ඒකයි කියන්නේ intramuscular එකේ 037 1430 එකට යන්න ඕනේ, intradermal නම් 03730 schedule එකට යන්න ඕනේ කියන එක.
All right, madam, we can continue as intradermal also. There is no mandatory that has to be IM.
නෑ. ඕගොල්ලෝ hospitals වල ගහන්නේ intradermal ම තමයි. With serum intradermal. මම අර IM දුන්නේ, there are some instances where you have to give IM ARV. Immunocompromised patients, people who are like foreigners or international travelers, or in the private sector. Those are the 3 indications where you have to go for IM schedules. Okay?
Okay, thank you.
Otherwise,
Thank
don't
you.
waste this by giving unnecessary IM. You are using a lot of ARV.
Okay, thank you, madam.
Okay. Then shall we call it a day? Shall we stop it today? Okay, no response. Thank you very much, everybody, for your patient listening. And I'm happy you all asked a lot of questions. And I hope this lecture will be useful for you all. And as Dr. Mithun mentioned, in another 3 days' time, it is 2 days, the 28th. It's tomorrow, no, the day after. It's a holiday, and that is considered as the World Rabies Day. So I'm happy that we could do this program today. And for your to have a like kind of a refreshing, like to refresh your knowledge about how to do proper post-exposure management. And I think Dr. Mithun will tell you